afternoon, everyone, and welcome. I welcome you all, and thank you for taking time to kind of join us in this critical and timely discussion. I also want to kind of thank the Health and Housing Consortium for just bringing us here today to kind of dive into this important issue. And I guess as Amy mentioned, my name is Tanisha Hines. So before we introduce the panelists, I wanted to take a few minutes to share the aim of this panel discussion. As many of you know, New York City has been the American city hit hardest by the COVID-19 pandemic. Not all New Yorkers have been equally at risk. Age has been a serious factor, and nearly 75% of New Yorkers who have died from COVID-19 were all 65 and older. The impact of the pandemic on the aging population has been severe and has led to mounting concerns for continued risks of underlying health conditions. And for millions of vulnerable low-income older adults, coronavirus has not only just been a food insecurity issue, but really has been, disconnected older adults even more so from the communities, kind of due to social distancing. I think right now, as many of us know who are working in this space, there's no longer, the same access to community centers, no longer access to social workers, and, other support systems have really been disconnected across the board. And I think it's really a alarming time, given that studies have cited social isolation has just been associated with a number of chronic illnesses, including heart disease, dementia. So it's really a time that older adults are even more so vulnerable across the board. Beyond this, race and class have also been influenced, and I think outside actually older adults, just across the board. So where you have like Black and Latino city residents have died from COVID-19 at twice the rate of white or Asian New Yorkers, and the zip codes in the bottom 25% of average incomes represent 36% of all cases of the disease, while the wealthiest 25% account for under 10%. So I think, just really paying on that point that, I think as COVID-19 has, happened, I think what we've all seen in equity across the board has really shown and, honed in on a lot of these social issues that we're seeing. And it really impacted Black and brown communities, at higher rates than, white or Asians. I guess in addition to, alongside the COVID-19 pandemic, the homeless population is aging rapidly, which we, many of us know, creating, I think specific challenges and urgent needs in both housing and healthcare sectors. Before we go further, I wanted to ask the audience today a couple of questions and kind of just hear from everyone, give folks an opportunity to, kind of a warm-up icebreaker to actually answer the questions. So the first question that I would love everyone to take an opportunity to answer, in 2010, how many adult homeless men in shelter in the US were 46 to 54 years old? So I'll give folks a few seconds to actually take a moment to answer. And you can actually just put your answer into the... Okay, and if you guys are also starting to answer the second question, that's fine as well. So the second question is, Black and Latinx individuals make up over 85% of the New York City single adult shelter population. Okay. So for the for the first question, I think many of you, about 46%, got this answer right. So 1 in 3 adult homeless men in shelter in the U.S. were 46 to 54 years old. And I think the second one, astoundingly, almost about 96% got this right. So it is true, about Black and Latinx individuals make up over 85% of kind of the New York single adult shelter. Thank you for participating in that. And here is just a demographic, just a kind of really showing the breakdown. So I think where you see a large percent, almost 50%, of about 58.7% actually are Black individual adult men, singles making up the shelter, and then almost 26.8% for Hispanic. So, I think I think the stats itself are really telling. So, I think in New York City by the year 2030, it's predicted the population of adults, both 65 and older, living in shelters is projected to nearly triple, which I think is really alarming. And I think what we recognize is that, you know, our society, currently is not prepared for, the projection, and, don't have the necessary resources to really support seniors and older adults, and specifically those who are residing in shelter and, needing, support services as well as, stable housing. So in fact, I think aging is taking place in all classes of housing, whether it's congregate shelter, supportive housing, or naturally occurring retirement communities. Each speaker here has different perspectives of these settings on what services and policy interventions are needed in order for their clients and patients to live healthier lives. As a community supporting older adults, I think our shared goal here is to ensure that those aging remain healthy, connected to services, engaged with their communities through affordable and accessible housing. And I also want to take a moment, as we're going to this discussion and really, listening to the panelists and also, answering questions and asking questions, to kind of remind everyone that, we're here not to just learn, but to really think about ongoing opportunities to expand resources. This means thinking about current challenges that we're facing, both from the pandemic and outside of the pandemic, and really sharing resources to amplify the solution. So really, hoping that everyone here, as we're talking is, looking at this as an opportunity to also, us as a community to kind of share and think through what we can do. I think it's going to take a suite of tools and resources and community stakeholders here to address all the challenges from the pandemic faced by our older adults. So with that being said, I'd like to briefly introduce the panelists. For a full bio of each of the speakers, please look at the screen. So I'm going to quickly start in order. So I would love to, first introduce Jocelyn Groden. So we're very excited to have everyone here. She's an MSW, and she's Associate Commissioner of the Bureau of Social Services, Direct Services, and Elder Justice at the New York City Department for Aging. She began her career in aging services in the late 90s. She has held a leadership position in aging, mental health, criminal justice, and homeless service in city government for over the last 20 years. Prior to her return to DIPTA in 2019, Ms. Groden was Assistant Commissioner of the Quality Assurance and the Improvement at the Administration for Children's Services, Division of Youth and Family Justice. Secondly, I would like to introduce Christine Montenez. She's an MSW and she's a lifelong resident of the Bushwick. Serves the community through her work as a Director of Supportive Services in Riseborough's Housing Division. Christine oversees the coordination of supportive and social services, including comprehensive supportive services for formerly homeless or at-risk families and individuals. She also serves 8 Section 202 senior housing facilities and a 30-bed Moffett Gardens assisted living program. Christine received her master's in social work with a focus on organization management and leadership from Hunter College. Third, I would like to introduce Amy Shelford. She's an MSW and is a 30-year veteran of JASA. She's serving as the agency's co-chief program officer of residential protective and legal services. Amy has played a leadership role in expanding JASA's services continuum, particularly in the areas of the North, supportive services, case management, elder abuse prevention and intervention and tenant services. And then lastly, but not lastly, but last but not least is Dr. Batra. She's served over 20 years in medical clinics in New York City's homeless shelters and SRL hotels. Since 2002, she has been the doctor for the 275-room Woodstock Hotel, SRO, in Times Square. Operated by Project Fine as supportive senior housing. The clinic cares for about both homeless visitors and building residents and was founded in 1981 by St. Vincent's Community Medicine Program, now a part of NYU's Family Health Centers. So with that being said, one, again, I want to take a moment to kind of just thank all the panelists for, talking with us today and, bringing your expertise. And I think to kick us off, we're going to have Jocelyn speak a little bit.
Hi, hi everybody. Thank you so much for this important opportunity to speak about my favorite people, older adults and the importance of housing and social service during this particularly difficult time that's been a challenge for all of us, and recognizing the particular impact that it's had on older adults. Throughout the public health emergency, the Department for the Aging has remained steadfast to make sure that the health and safety of older New Yorkers are a priority, and to transition our services, including food provision and addressing social isolation throughout the pandemic. Next slide, please. New York City is home to approximately 1.64 million older adults, a number that all of you know continues to keep growing. Our mission at the Department for the Aging is to eliminate ageism, ensure the dignity and quality of life of diverse older adults, and to help older adults age in place through a variety of services, and I'll talk about a few. Some of the things that frequently come up are naturally occurring retirement communities, case management to help more vulnerable older adults remain in home with home care and home delivered meals, programs that also support the ability to stay in the community, which can include the bill payer program or high cap to help people navigate the healthcare and insurance system. Another thing we think about as we help older adults remain in communities and stay safely at home is how do we promote full and active aging and combat ideas around ageism. So some of the things we do, I think the most notable thing we do are our senior centers, which have about 25, and before COVID had about 25,000 attendees coming every day to receive congregate meals, and things that support the mental health of older adults, like mental health and friendly visiting programs, which we've actually expanded during COVID-19. We also have services that help economic fragility and help people remain productive and connected to work and their community through opportunities through our senior employment unit, our foster grandparent center, and our volunteer resource center. We also work in partnership with our community-based partners, such as JASA here on this call today, to promote elder justice by preventing and addressing elder crime and abuse. Next slide, please. So as mentioned, here we are in the second wave. We're hearing the numbers continue to grow, and older adults have been some of the most impacted and affected, largely staying home except for doing things like meeting essential needs through March, confronting a parallel pandemic of both COVID-19 and social isolation, including a loss of community, experiences of grief and loss that we're seeing in older adults as well as in our social service community. And more clients than we've seen before showing up in need of food, case management, home care, mental health. We're seeing increases to our elder abuse referrals. We're seeing increased instances of elder crime. So we need to continue to work to show up for them and to pivot our services, most of which have been pivoted during the pandemic at Department for the Aging through our partners. Next slide, please. Since March, the city has developed a multi-pronged strategy to quickly reach seniors with unmet needs and connect them to food, mental health, programming, and safety. One of the biggest things we've done is to launch DFDA direct meals and have served since March over 650,000 meals outside of our traditional home delivered meal program as a means of pivoting all of the food that people were receiving daily in congregate centers to direct delivery. We also have launched campaigns around social isolation and elder abuse to really promote the call to action, which includes asking members of the community and all of you to be part of our work and to reach out to older adults that you know and check in on them, make a call, make sure that they're okay and they're getting what they need. We've made over 2 It's actually 2.4 million wellness calls since March. The number continues to grow, having reached out to about 183,000 clients as part of this work. We've also continued service delivery to about 200,000 clients through a holistic approach that includes a range of services. Next slide, please. A big part of our work that we've been thinking through and has certainly showed up more than ever is how do we address the digital divide? So some of the things we've done, we've pivoted almost all of our senior center our senior center programming to virtual. We have almost 200 centers providing exercise classes, bereavement supports groups, arts and culture, educational opportunities, and social and mental health support, such as geriatric mental health. As we continue to pivot this work, we see the opportunity to bring on more and more people and connect them safely at home to these supports. We've also partnered with NYCHA to distribute over 10,000 tablets, which includes wraparound services such as education and older adult specific help desk support. Next slide. When we think about housing security, Department for the Aging is not particularly in the business of housing. We're in the business of keeping people at home. We have Aging Connect. That is our point of entry for any needs. We have a small housing unit, a home sharing program, and a sign council project, which works closely with clients showing up in housing court to mitigate any potential eviction. We've also forged close partnerships with the Mayor's Office of Tenant Protection, NYCHA, HRA, HPD, IHAC, and others to work together as a community and with our sister city agencies to address the housing crisis. Thank you so much.
Hi, good afternoon, everyone. Can you hear me?
You're all good.
Okay, great. Sorry, I couldn't see myself. Good afternoon, everyone. I'm really glad to be here with my esteemed colleagues. I just kind of want to give everyone a rundown of who we are at Riseborough and what we've been doing, not just with COVID, but just how we're serving our older adults in our housing and also in our community outside of the tenant relationship. Can you go to the next slide? So just a quick overview of Riseborough's divisions. We have a seniors division, a housing division, that's my home division, education, health, and empowerment. And we provide services. The way that we provide services is that we want the community to thrive, but the community is made up of individuals, right? So we want to make sure that every individual has what they need in order to make a thriving community. So that's the Riseborough mission. Can you get to the next slide? So the services that we have for our seniors and our older adults break up into a few different sections, if you will. So we have our housing, we have HUD-funded Tier 2 buildings, which include on-site social services, recreational programming, and care coordination between all of the services that are within the building, but also outside of the building for our tenants, including like local hospitals, home care. And within the buildings, we also have programming activities. We have art classes, computer classes, yoga, Zumba. We have health programming and social events. So we bring the building together essentially in like celebration, birthdays, holidays, which is what has made this time particularly difficult for our tenants, because they're used to coming together and they're used to seeing their service coordinators, they're used to seeing staff, and they're used to seeing their neighbors. So this time has been very difficult. We also have our senior centers that are through our seniors division. We have on-site, services, Medicaid, Medicare help, programs that help them with like fall prevention and health education. And we also have a home care, division, and that division provides home care, and that includes daily check-ins with their clients and medical referrals and assisted living assistance with activities of daily living. So and of course we have our Meals on Wheels program. So all of those are the services that we have at Riseborough that just like on a regular non-pandemic basis. And so all of these things kind of got pushed really to the brink during COVID, and we're still feeling a lot of that now, where we had to really pivot, as Jocelyn said earlier, pivot our services to really kind of fit the current climate of what we're experiencing, and shift a lot of our services to meet where clients are now and where tenants are now. So use the next slide. I kind of broke this out into how the services that I oversee, what our approach is in keeping our older adults safely at home. So one of the main things is connection and collaboration. So, we understand that we house them, right? And we have services on site for them, but that's not the only thing, right? There's a lot of other pieces. Each person comes with a network of either support or lack of support, and we kind of have to figure out where that gap is and work to fill that gap. And so making sure that they have support networks, and if they don't, help them to build social capital so that they're not just relying on their service provider, they're not just relying on their service coordinator, because as we know, during this pandemic, when folks are working from home and there's a lot less access to people, it can become very difficult for those who are dependent on their service provider being on site. So we make sure we refer folks to necessary services, provide access to local resources for older adults who live in multifamily settings, who maybe don't live in a 202 building. So we'll have our housing division. Every time that we have tenants move into a unit, they get a packet of like local services, whether it's through Riseborough or in the area, and that includes a lot of the services within our seniors division for our older adults who are moving into our buildings and not in a building that has on-site services, and so we make sure that we create a space and opportunity for social engagement and community building, and also empowering older adults. So educating them on issues that are affecting them and ensuring that they're included in conversations about them, right? And that we're not making decisions on their behalf, and that we encourage them to do a bit of self-advocacy whenever they're seeing a doctor or getting home care, that they're getting everything that it's tailored to them and that they actually need, and that they're part of the conversation. What's the next slide, please? Cool. I will try to get to this very quickly. I know I have 2 minutes. So the changes that we had to kind of pivot to during COVID, when the senior buildings, new ways to engage with our clients. We stopped home and office visits. We, to make sure that staff and tenants are safe. Group activities and case management was pretty much done over the phone or video. So the issue there, though, is that a lot of there is that technological divide. A lot of our seniors and our clients didn't know how to use things like Zoom, and now they've gotten a lot better. So we had to kind of use, whether it was Zoom or whether it was, thanks, Harmony, whether it was Zoom or Facebook Live or like WhatsApp or a FaceTime. So we had to kind of see what tools they had and use those tools. And we're working with getting them, more acquainted with Zoom so that we can get a group together. So we're working on that now. What we did as far as like checking in with them, we did telephone reassurance calls and wellness checks. So we did those right at the beginning of the pandemic here. We did them twice a week. And it was really to just make sure that if we did need to go into a like stay at home, which we did, that they had the food that they needed, that they had the medication that they needed, that they had everything that would keep them safely at home. The issue with that, though, is that when you have a service coordinator with a building of 65, sometimes 90 clients, that person, if what they're calling to make sure, if what they're doing is calling to make sure that they have what they need and they're following a script to make sure that they stay on task, that then becomes difficult for the tenant. If the tenant has like anything on their mind that they want to talk about, like just emotionally, it's difficult for them, that service provider, to say, do you have everything you need? I need to call the next tenant when they have someone who is expressing, how they're feeling. So they have to then pause, because they're not going to leave someone just sort of expressing how they're feeling, but they have to wait, to finish their list that they're doing checkups on, to really kind of offer that emotional support. So what ends up happening, or what ended up happening, was we had a lot of tenants who sort of were starting to really feel that lack of connection with their service providers. So because we weren't having classes, we weren't having yoga or art classes, the recreational staff and the part-time recreational staff and instructors started to, call their students and call other tenants in the building and just speak with them for like 10-15 minutes and provide a lot of that emotional support. And one of the really successful success stories was like our art instructor. His class has almost shifted entirely to like art therapy. We're hearing from a lot of our tenants that is what they're really holding on to, is that connection that they have with each other when they're doing like a WhatsApp group thing or a Facebook group thing, and with the art instructor. So that level of connection with staff has been really important for them as well. And it's a new way to use those individuals that we weren't using them before. Next slide. Oh, that's it. I'm done. Thank you guys. Thank you all. And I think Amy is up next.
Hi, everybody. I want to thank the consortium for this opportunity. I'm very appreciative to be here today with my panelists. We could go, I am from JASA. We could go to the next slide, please. So JASA has been in operation for over 50 years, and we are built on 3 essential pillars. We have services, home care, and affordable senior housing. In housing, for example, these are 202 sites. We have over 10 buildings, and now we are also partnering with developers outside of JASA, providing tenant services and housing management. JASA helps older adults remain in the community with dignity and autonomy. We help people age with purpose and confidence, and we partner with others to build strong communities, because living in this city really requires probably a village approach to help keep everybody safe. Our services used to be organized geographically, but now are portfolio-based, and we offer a very diverse range and depth of programs, some of which are listed here, which you can see on the slide. And the thing about JASA is that, for example, we have 22 senior centers. We're involved in 12 NORC programs. We have 5 DFTA-funded case management programs. We provide home-delivered meals through 3 contracts in Brooklyn and Queens. So we have this broad array that covers many communities, and we're very pleased to partner with DFTA on most of our programs. We have our funding primarily through DFTA and the Human Resources Administration. So every year we help about 40,000 persons, their family members, and other individuals who are concerned about their well-being. We work to make service delivery very person-centered, to bridge some of the natural siloing that happens even in agencies. When you have a lot of programs, how do you connect people to the right array of programs and services for their supports? And right now we're particularly focused on making sure to help our clients not be defined by their vulnerability, not be defined by the fact that they are clients, but that they have strengths, they have preferences, and they have a sense of agency that we can support. Can we go to our next slide, please. So I'm going to talk something about the impact of COVID-19 on an agency of JASA's size and breadth. So in the middle, you see there's a circle of more individuals, growing number of individuals who have some sort of need. We know, for example, those who were vulnerable before the pandemic became more so. But those many people who were independent have come to see their situation as much more precarious, and they were cut off from their routines and usual support networks. I bumped into somebody at the drugstore yesterday at CVS, and a person, an older adult, who said to me, you know, this is our big outing for the day. It's very hard for individuals right now. So a couple of these arrows: social isolation and loss of community. And by community, I'm addressing this very broadly. Community is certainly geography, where you live, but it's also affiliation and family. Unfortunately, physical distancing translated into social distancing. Precarious management of the usual. Everybody is struggling with just managing ordinary errands, day-to-day tasks, medical appointments for chronic health conditions, putting off mammograms, colonoscopies, particularly necessary services for interventions for our population. Food insecurity. I think DFTA worked very hard to manage such a big challenge, and we're very appreciative of the effort, but we also recognize, as I think DFTA does too, that part of having to do this on a broad scale means that that clients don't always have as much choice as they would like. The big red arrow is about the virus-related illness, and we do know that with every decade beyond 60, the incidence of mortality increases. So there's the actual obvious existential challenge to our clients, and frankly, the accompanying ageism. I think that many of us were appalled by some of the comments and things we were reading, that some people were just proposing that older people should give it up in the name of the greater good, for the economy, for example. And so in addition to worrying about the actual physical impact of the virus, our clients were also subject to the anxiety of this. If I get sick, will someone see me as an individual? Will someone care for me as a person with people whom I love and who love me? So I will say, however, that attitude, the ageist piece, was also countered by an enormous rising up of what we saw as individuals in the community who wanted to help. Community people who wanted to act as volunteers for our clients. Okay, so let me move quickly. I just want to say there are several fault lines that were exposed. Racial equity, certainly, the digital divide around technological issues, and gaps in family and paid caregiving infrastructure. So what did we do? Can we go to the next slide, please? We want to enhance and expand the safety net. Improving agency capacity. We mobilize staff to new ways of operation, increase telephonic support, of course, across the board, but also increasing the staff in our help center, which is our telephonic information and referral program. As we partnered with other agencies, food pantries, established volunteer resource organizations, for example, the American Red Cross. We partnered intra-agency in new ways. For example, there's normally a firewall between housing management and services, but housing management was enormously instrumental in helping us distribute extra food during the summer, as well as conducting tenant checks triggered by by service coordinators. We worked very hard to secure philanthropic dollars to expand contract capacity. We modified service delivery, while we moved to remote operations for most programs, and paradoxically, this has resulted sometimes in more frequent client contact. Some programs, of course, remain face-to-face: community guardian program, adult protective services, home delivered meals, management, housing management, and service coordination. All of our programs are open, some more modestly, but vital service areas such as care transitions and peer health navigations are very essential right now to help people remain healthy. We implemented new safety protocols. For example, in housing, more frequent cleaning, guest check-ins, closing off of group spaces, distributing PPE to our tenants. We provided new opportunities for connection and engagement with our JASA Chat program, a telephone and virtual visiting program that pairs individuals, community volunteers with clients for mutual reciprocal conversation, also operated at extra ears for us so that we would learn about client concerns. We distributed food through a philanthropic grant. And we've tried to promote resilience to help our clients understand that physical distancing doesn't have to mean social isolation. In all client contexts, but particularly that was important through JASA Chat, we increased the numbers of peer support. For example, right now in our elder abuse program, we're doing a one-on-one support program between an individual who has been victimized by elder abuse but has come out of it to help someone new to our program services who is just experiencing the vulnerability that happens when it's first acknowledged. I also have information for supporting the workforce, but I think we're going to address that question a little bit later, but that's a very important element of how JASA pivoted. Thank you.
Dr. Batra?
There she is.
Should be there. Okay. Hi. All right. Hi, everybody. Thank you so much. It's an honor to be here.
Yep, we can see you.
You
And
can
hear
see?
you.
I
Yep.
can't see. Okay.
Oh,
right.
sorry.
Hi, everyone. It's an honor to be here and to meet and hear from all of you and learn from you. Today, I'm going to talk a little bit about the nitty-gritty. I'm Dr. Mira Batra from Community Medicine program at the Woodstock Hotel. Next slide. So we're founded in 1969. Our program, you can see the photo on the right, is Dr. Philip Brickner making a home visit, and he hired me. He's one of my heroes. We provide care in homeless shelters, SROs, and substance abuse programs throughout the city. We have 9 clinics now, part of an FQHC. We opened this clinic in 1981. It's a full medical service clinic, and we have everything you need. I'm here since 2002. I'm all over the building. I'm in the senior center, the homeless shower room. I'm here 3 days a week, and we have after-hours coverage as well. And we have a very, very nice, positive, long-running relationship with Project Find, wonderful organization. Next slide. So I always say Woodstock is full of life, and as we've alluded to, it's a village. It's built in 1903 as one of those traditional hotels in Times Square. Every room has their own bathroom, but no kitchen. Anything you plug in, you can use to cook with, but no kitchen. It's level 1 supportive housing, and since 75, I think Project Find has been here. It's the last left from a pilot program from the city in the 70s. Some of these SROs were kind of falling down, and they decided to put social services in there. Residents are 55 and older. Our oldest is 94. You'll meet her. Most are formerly homeless. They come from a range of backgrounds, most low income. 275 tenants, majority male. It's a housing stability model, as we refer to in other speakers. Funding from DHS, DFTA, and other agencies. And everything is provided as an SRO hotel model. So they have laundry, housekeeping, all these wonderful activities, senior center, cafeteria, and the shower room, and homeless inmates is there for our street homeless over the age of 55, which is an important service that they provide. So on the photo, you'll see Madam Maggie, and they have a monthly jamboree, playing music and having a great time. Next slide. So here's my sign. It says, "Coronavirus, keep out. You are not welcome at Woodstock." I put that sign on the front door. in March when we first started hearing about this virus. And the photo there is of Bryant Park in the spring, completely empty. Nobody was around. I was very nervous. I was freaking out. I actually wanted to wrap the whole building in saran wrap and move in. It was, for me as a physician, a very big challenge that my patients were in the crosshairs of this pandemic. So our usual infectious disease protocol, as we always say, is prevent, test, and treat. So what does that mean? They always say, think like the virus. In this case, we didn't know what this virus was, what it's going to do. It was very uncertain time, and it still is. There was a lot of changing on the guidance, the protocols, the PPE, the hygiene recommendations, and then I don't know if I'm carrying it when I go to see my patients. We didn't have the ability to test. And I had a great challenge of just getting my patients to take it seriously, and I still do to this day. What I found was that my patients have low health literacy. They're very individualistic. They've been alone most of their lives. They don't want to change their routine. They just had a lot of factors that, based on their background in different ways, it was very hard for them to conceptualize this virus. And they didn't want to complain when they were sick. Some patients, fortunately, did remember things like polio, swine flu, measles, or HIV. So I tried to use that as a way to inform them. My great partner in this was the governor. When he started going on TV, that was a great day for us, because finally I could say, look, just do what the governor says, watch the TV every day. And that became a great way for all the patients to bring it home. Okay, that was very helpful. So that's also a picture of Mr. Carlos in his homemade PPE. He's covered in about 8 layers. Next slide. So, oh, sorry, I got my slides mixed up. So what were some of our challenges and innovations? As I said, making it real, trying to be creative, keeping it personal, being very, very hands-on and available at all times for the patients. I just tried to be all over the building. We were able to use telemedicine, so that's a new thing that is covered now by insurance. So I could do phone or video visits for patients, and we did have to close our waiting area at one point. Or we didn't have enough staff because they were out sick. We did door-to-door phone, visits, wellness checks, as well as the staff at Project Find did. I encouraged everyone to plan. Do you have your medications? Do you have food? Do you have doctor's appointments? And everyone got an EMS packet in case they were sick. That was a big priority for me. Grab this packet and go. I did referrals for VNS, telepsych, and I already have this daily sign out to Project Find. Every day I email them, and we really tried to coordinate very closely throughout the day, being each other's eyes and ears. Sometimes I would knock on the door and they would say, oh, Peggy just left. The social work staff was staggered. They were working at home. The other thing I had to do very heavily was education. I had to make it easy. The wolf is at the door. Your room is your PPE. Stay home. My little certificate is there. COVID pandemic support certificate. And I even dressed up as a virus to try to get it to be real. I went around and scared everybody in my green virus outfit. We are testing now since May. Thankfully, everyone has been negative. And here's some pictures. I have Miss Doreen, my oldest patient. She's 94. She's FaceTiming for the first time in her life. And on the right is Miss Kathy. We celebrated her birthday. We really tried to be there for our patients in every little way we could, although they're not wearing their mask correctly. Next slide. So Project Find had challenges and innovations on their own side, which we've all discussed, our different panelists. They did provide temperature checks, hand hygiene stations, twice-a-day sanitation. The housekeeping staff was redeployed, so they were out there wiping things down, social distancing, and they provided masks. And we kept a list of who had a mask and who needed one and who wasn't wearing one. The meals, we already spoke about everything. The hallway right now is full of food. The shower room had to change their hours to stagger the patients. The meals pickup for the homeless was moved to another building, which I think was a little hard for them because they were used to picking up the food at the same time, but it works. They closed the public areas. And this had a ripple effect, which we'll talk about later. meetings were put onto Zoom for the tenants, different activities. And we also did a lot around assisting people to mail in their ballots and get their benefits and things online. There's sort of an informal buddy system in the building with neighbors and people watching over each other. So we actually tried to reinforce that and say, look, you got to be our eyes and ears. We all have to help each other right now. And as we said, we had a very organized, systematic approach with the social work staff. They have a watch list, they had a questionnaire, and it worked really well. We were just in contact all day. Photo-wise, so I said, in a word, communication. So that's Miss Janet in her special vaccination blouse, which has a cutout over the deltoid muscle. And on the top is Mr. Harvey and Miss Bev. They're doing socially distanced, hanging out with a Starbucks coffee. And on the right is Mr. Hiroshi. He's going to his dialysis, totally bundled up. Next slide. So what were some of the outcomes? I call it the ripple effect, and it's still rippling right now. We had some residents who were definitively COVID positive. They went to the hospital and they were accepted for treatment. Some were discharged to a nursing home, and some of our other hospitalized patients went to nursing homes. And at that time, there were a lot of nursing home COVID cases. So I was not a fan of nursing home discharges unless it was really necessary. We had a few who were very sick with COVID-like symptoms. I was not able to test, but when I called the emergency room, they said, do not send them in. We don't have room for them unless they're going to be intubated. You're on your own, doc. So I tried to care for them at home, and they all pulled through, but it was scary. Some of them did not want to tell me they were sick because they had been watching on the news about the overwhelmed doctors. So they were kind of holding their, holding on to their symptoms. We had some deaths in hospital and nursing home patients, which were confirmed COVID, and we had more than usual found deceased in the room. This is something that I don't know what the factors were on that, but that was very difficult for all of us. It was hard. We couldn't find people in the hospital. We couldn't find them in the nursing homes. We would call, no one would pick up the phone. It was really very chaotic. And sometimes the patient would just show up back from the hospital. We couldn't, really track them. What I'm calling it now is the stay-at-home effect. So deconditioning, falls, isolation, as we talked about, of an already isolated group, boredom, loneliness, grief, depression, anxiety, a lot of fear. And this is a very stoic group. They don't want to complain. So you have to really elicit. We've got the chronically frail elderly who have not had COVID, but were just kind of very fragile health-wise. We had them pass away, and I don't know what the reason was. People who were taking 18, 20 pills a day and just hanging in there fine, but then they passed away. And I had some new cases of diabetes, heart failure, weight gain, weight loss, infestations, and neglect of existing diagnoses because lack of existing care for their diagnoses. They couldn't get to their primary care doctor. So I was able to bridge the care in that way. But they didn't always say. I would see that the pill bottle was empty and say, what happened to your doctor? I don't know. They're not picking up the phone. We had a lot of issues with staffing. We had to cancel our students, our navigators. And then everything across the city was closed, as we know. And it was just that much harder. Again, the digital divide, the hotel buddy system, and just family separation and isolation. I think this is the greatest thing right now that we're dealing with is isolation and fatigue. Trying to get everybody to still feel like part of a community and keep wearing the mask, keep following the protocols so that we don't get that second wave. And that's all I have for now. That's a picture of the hallway at the Woodstock. Thank you so much.
Okay. Hi, everyone. I think my video's on. Well, one, I want to thank all the panelists for their really amazing presentations, really informative. So, thank you for taking time. And I know, I already saw some questions coming into the chat. So I wanted to take some time to ask a few questions, just really calling out some common themes. And just as I was listening to the presentation, thought it was really important to kind of hone in on. I think, one of the items that really keeps popping up, and I think I talked a little bit about it, and I heard some folks bring it up in their presentations, is really talking about kind of this racial inequity that continues to pop up, that we're seeing even more so because of COVID, really just highlighting what we're seeing across the board. And, I wonder from some of the panelists, and just hearing your perspective on this, like, how do you think we can bring kind of a racial equity lens to our understanding of the current health and housing issues facing older adults in New York, and, really work towards efforts to address them? So if any of the panelists have any thoughts on that.
I'll just jump in really quick. So earlier this year, I heard an address from activist and educator Brittany Packett Cunningham, and she was just talking about the work that she's done and kind of like what she's learned. And one of the things that she said really stood out to me was that a lot of systems conspire to create the inequities that we see, and so the reverse has to be true, and a lot of systems and a lot of things have to conspire to undo those things, or at least start to undo those things. And I think that that it really struck me because it was kind of like, it's an obvious answer, but it was one that it really didn't hit me until I heard someone else say it. It's that this didn't happen overnight, and it didn't happen on its own, and it wasn't even unintentional. A lot of this stuff happened because it happened on purpose, and so we have to, on purpose, decide that we are going to work together collaboratively. What role did each of us, and maybe not as individuals, and maybe not as like in each of our organizations, but what role did we play in getting here, and what role do we now have to play in getting out of this situation? So I think that it's really kind of like being honest about where we are, and that's hard in and of itself. I feel like a lot of folks have a hard time with really kind of saying, yeah, this is what's happening, here's how we got here, and understanding that each of us in one way or another are part of all of it. So being very honest about that, and saying, what can I bring to the table to help undo that? And I think that even that, like, collaboration really will go a long way. But it's going to take very, very difficult and honest conversations, and people being bold about where we go from here.
Yeah. Thank you, Christine. I think that was an important point to really talk about the systems and, actually undoing those systems. I see Amy, do you want to answer as well?
Yeah, I just want to add, I'm in full agreement with how Christine presented it, and also to note that, and obviously it's sort of, we recognize at JASA, it starts with us. And in fact, we've embarked on what will start a year-long initiative about how to help, how to foster an inclusive culture. And while it starts with staff at all different levels, all sorts of opportunity, group meetings, large groups, small groups, discussion groups, we've been also thinking about how do we engage with our clients on this as well in various programs. How do we use these opportunities to make this issue very conscious at both in terms of what it's going to take, where are we at, what is it going to take to change it, how did we get there? There are so many different levels to it, and it requires very sort of a dedicated, purposeful focus, which is difficult, but what we're trying to do.
Great. Thank you for that. Does any of the other panelists have any thoughts on that question?
Yeah, I'll add to that from a government perspective. I think I'm the government person on the panel. First, inequity never shows up more than it does in a crisis. I think government, I think you have to be deliberate and intentional, not only in your conversations, but in thinking about the resources and tools you have to create an inclusive culture. So some of the ways that we approach it is through our contracting, making sure our contracts reflect that and are pushing into the communities most in need. And also data collection and analysis, where are we missing? Who aren't we serving? Why? How do we address that? So these are tools we're regularly deploying and looking at to continue to push ourselves to do better.
I would just like to add one thing to what Jocelyn's saying. It's very important that it's, as Jocelyn noted, that it's integrated in service delivery, in other words, into purposeful work and how we engage with communities, but it requires us also to recognize we're not going to do this on our own. We have to, how we partner with different groups that have different constituencies and those who are affiliated in different ways. It really, as I said, it's a consciousness on lots of different levels in terms of personal and professional engagement.
Great. Thank you for that. So another question, and I heard it across the board, and folks talking about what they've implemented thus far, and I think for most folks, we know that at the moment and for the foreseeable future, COVID-19 has impacted the way we do our work, and it's going to continue. And I guess specifically impacting older adults, what are some of the innovations and best practices that, some of the panelists may have seen have emerged during this time? Is there anything that could be scaled more broadly, or anything that, should continue as we, think about this new world?
I think one of the most relevant things that I think all of us talked about is conquering the digital divide. So we've distributed more than 10,000 tablets. We have more older adults than ever accessing services virtually, which includes tablets and laptops. It also includes things like the telephone, but really scaling this work up. So we've initiated a number of thought partnerships and focus groups with our providers to think about how do we continue to scale this work and how does it live on in perpetuity once we return to normalcy. And we certainly imagine this being a game changing. We're never going to go back to the way things were. And I think in the future, there's a lot more of a hybrid model, which really pushes services to traditionally homebound, vulnerable older adults who often don't have access to these in-person congregate settings.
Yeah, I think that's probably one of the most important pieces to how things are going to have to shift. And it's like there's a little bit of a triumvirate of need there. People need the equipment, they need to be able to afford the Wi-Fi access, and they need ongoing training to help support what they're interested in doing. We had one building that we were able to wire prior to the pandemic, and we were able to secure funding to distribute tablets. And one woman was able to speak to a family member in another country, someone she hasn't interacted with in such a long time. So that particular kind of experience was so meaningful for her. I'd also like to add that one of the things we're starting to think about is, do we shift to a facility hub kind of model, so that do we actually need a facility for each program, or can there be more fluidity with how staff use office space, conduct visits? There's lots of ways we're thinking differently now about physical presence and how we engage. That could be adaptive, and money from that could obviously be saved and applied to other service delivery or enhanced service delivery.
I think one of the things for us that it goes back to the conquering that digital divide, but we have at some of our buildings, some tenants who are completely comfortable with technology before it now, and have, I don't want to call them have kind of become sort of like ambassadors with their neighbors, and kind of said like, oh, you don't know how to use Zoom, you know what, I'll give you a call and I'll show you how to walk through the steps. And and it's been exciting because then it one lessens it what staff kind of have to like sit there and walk through them with, but it also I think creates more of a sense of like unity between the tenants, even though they can't like see each other as often physically or sit together as often as they used to. I think it creates a level of unity. And also, I mentioned this before, I think I have not heard a complaint in the last 8 months about like, my neighbor did this to me or the other one did that to me. And I think that it's because everyone realizes we're in this together, and how to look out for each other. And I think that is something that I would really love to continue to see past COVID is like the neighbors really watching out for each other and taking care of each other in that same way.
Great. Anything else? Okay. And I think, I think we know like the common challenges, I think across the board that continue coming up. And I think I'm interested to hear, I guess, from everyone's perspective, are there challenges that we aren't seeing and, we aren't talking about, and where can we be potentially doing better as a community to really start to begin to have that conversation and address them?
Well, I think, overall we've been conscious that there's been a growing consciousness of the need for kind of interdisciplinary work. I mentioned earlier about the idea of breaking through silos of how we work together. There's that issue that's very important. The financial uncertainty right now in funding is a big burden. We can't solve it at this table, but that is that's a huge worry for not-for-profit, for the sector, on how we move forward, as well as just the idea of what kind of contract deliverables are we looking at? In what ways are we going to have to change our service delivery? So there are some challenges. I think that improving interdisciplinary collaboration, maybe some coordination of government agency. I know that DIFTA and the police department are working now together on how to best help older adults. That's a great start. That's how does everybody come together in the face of a pandemic? And obviously for older adults and for other cohorts in the population.
Great.
So working off of what Amy just mentioned, a few of those things, all of those things really resonated. I'll add to that, this is such a great moment, an opportunity for innovation and forward thinking. I mean, I'll say one thing about the aging service system. A lot of it has lacked some elements of that, and this is really the opportunity to push our older adult center into the future and look at what is the role of technology and how do we bring more younger older adults in and really use this to move us forward. Definitely, as Amy mentioned, city government is big. There's a lot of city agencies. Some of them are pretty large. I've been doing this for 20 years. I've never seen silos broken down in the ways that they are now. We talk to NYCHA all the time. We talk to HPD. We talk to homeless services. We're working with different housing partners. We're working with food service delivery networks. We're working with the police department. Amy and I are working together on that to really hear older adults, to hear service providers, and use this as an opportunity to listen, learn, and do better. I think other things we could do more of is to really create more remote employment and volunteer opportunities for older adults to work and remain active virtually. And we certainly need more technology, better Wi-Fi, tech education, and help desk support that's senior specific. And certainly the financial challenges are palpable when you hear about lines of older adults at food pantries and the potential end of the eviction moratorium. I mean, these are all concerns for everyone.
Great. So a couple things keep coming to mind, and I think it's funding. and I know it's kind of big picture in the sky, and we can only dream. But I think specifically, do folks have any thoughts on the panel, just around maybe potential ideas for funding or policy changes, and kind of thinking a little bit more, like I said, pie in the sky and opportunities for collaboration across.
Well, we've been at JASA, we worked really hard to identify ways of expanding government dollars with philanthropic funding. And any way we can get the kind of sort of the conversation moving collectively. In other words, maybe identify certain areas together and see how we can put our heads together. Look, there's no way around it. We know there are going to be challenges financially. And while government can't do everything, at the same time, neither can not-for-profits make up, the difference when services aren't fully funded. But maybe getting more people to the table together is a way. Traditionally, philanthropic dollars are usually used to, let's say, start a pilot and trigger maybe a government response to continue that. But maybe we have to look at it from a different lens, given the current experience. For example, just what it's going to take to leverage technological equipment and training and Wi-Fi access for this huge population. That could be like just one area that is a collective focus on everybody's part. It's the money issue is a tough one.
Yeah.
Yeah, we need to work together as a city, as partners, to really amplify the message and need of older adults. I mean, it's hard to think of almost any social issue that doesn't impact older adults. So, I mean, I think it needs to be part of the conversation in every space, and we really need advocates to go out there and partner with us to push these messages. And similar to Amy, even though we are government, we also work with the Aging in New York Fund, and also look for opportunities to get grants and to be, as resourceful as we possibly can during this challenging time. But there really is more advocacy that needs to continue to occur.
Thank you for your thoughts on that. So I wanted to ask some specific questions for some of the panelists that came up. I think from my perspective, just so Dr. Batra, you spoke a little bit about, in your presentation, I think it was really amazing, just talked about, direct work with the residents and really trying to kind of qualm some of the health concerns, are there other methods that you've been able to utilize, which is really kind of mitigate health concerns with some of the residents that you've been working with specifically?
Me, as far as specific things we do?
Yeah, like I think you spoke a little bit about in your presentation, just talked about, really trying to mitigate some of the health concerns for residents. Are there other communication or tools that you guys are utilizing to kind of help with that?
It's really just a day-to-day thing. And I always say, and I tell my students and I tell my colleagues, there's no substitute for knowing your patient and knowing what they need, who they are. And that iceberg, the tip of the iceberg is someone says, oh, I just need a refill. But then when they sit down and you talk a little bit, there are all kind of things going on. And there's just no substitute for being on site. We didn't close, I didn't take a day off. And there's no real magic formula because each person is an individual. And as someone gets older, they, in my experience, become even more of who they are and more of an individual with very strong preferences and life experiences. So I tried to look for the silver lining in all this. I think there are a lot of silver linings we've been talking about, and fast forwarded some things that maybe were on the back burner that we knew we needed to do, other things that has brought to a crashing halt. But there's, I think, just to know your patient, know your setting, and anticipate and plan. Always plan ahead. Always think about Murphy's Law. What's going to go wrong? Our local pharmacy closed that everyone could walk to. So that was just an obvious thing that would happen because it's in Times Square and there's no business. So constantly thinking 4 to 6 weeks ahead has been really helpful for us, and communicate in any way, shape, or form that we can with our patients, with our colleagues, and being there. Just knocking on the door and checking on someone and saying hi. Even sometimes I would have an excuse to deliver a piece of paper that I could have put in the mailbox to them, but I would just stop by, maybe someone who didn't want to come to clinic and was kind of avoiding us. And I would knock on the door and say, oh, I printed out this little whatever form, and I thought I would give it to you. And that gave me an opportunity to look in, see, was their laundry piled up? Was there a bad smell? Are they dressed? Did they seem groomed? Or did they look kind of out of it? And every little thing adds up when you're working with older patients. And they appreciate it. I felt that they were very, very appreciative of us. And we work with their strengths,
Thank you. So for Christine and Amy, can each of you kind of discuss or just share, COVID-19 effects on staff and their capacity to kind of continue to help older adults? And, we know many folks on this call are actually working in organizations serving older adults, and, love to hear kind of best practice on what's been working for you guys, and, kind of thinking about the staff and kind of how to maintain stability of this workforce.
Sure. So first of all, I have to give a shout out to our amazing staff who are enormously dedicated and hardworking and pivoted to new ways of operating. But we recognize that we had to protect their safety and well-being. If we're going to be able to help our clients, help older people in the community, you've got to have a staff that is safe and able to do it. By the way, we've not had to close any programs or terminate any staff yet, which has been an enormous deal for us. So most of our programs are operating remotely. That means, a lot of client contact telephonically, and this offers some degree of flexibility, even in terms of hours. We've been able to alternate. People might have kids at home. Maybe they need to work, let's say, from noon to 8 instead of normal hours. And that's good for clients too, because it's a way of reaching people in non-traditional hours. Good for staff, good for clients. We have some essential staff in the field. I think I mentioned Adult Protective Services, Community Guardian Program, home delivered meals, and we were able to secure philanthropic funds to offer a very modest salary differential and cover transportation. For example, our Adult Protective Services staff, they're going all over the city. They can't be on public transport. It's not an efficient or effective way of managing so many face-to-face visits that are required. But unfortunately, those philanthropic dollars have ended. We're a little bit stuck now. I don't have an answer to that. We provided extra training and coaching for our staff, and particularly around team building, addressing grief and loss, and how to manage working during this time. Small thank yous, gift cards, lunch and learn opportunities where people could just come together informally to sort of generate a sense of community from across programs. And I think, certainly it's a positive thing that we're doing this Belong at JASA initiative, which is another way of supporting our staff to feel with this inclusive initiative. By the way, it's not to say that there aren't problems. For example, in Adult Protective Services, people are out because of illness, or they're out because they've been exposed to illness. Caseloads have increased markedly. So we have challenges, and it's hard to recruit for positions during this time. If they're it's one thing to be recruiting for a program that is remotely staffed, different if it's face-to-face. And that's true for our housing as well, because people have to be on site. So there are challenges, but we're trying to find different ways of supporting staff.
Great.
And I think a lot of what Amy mentioned is kind of what we experienced as well. I think one of the biggest things that I didn't even realize would hit us so hard, we did have very early on, we had a lot of deaths, that some of them were COVID-related or were COVID, and some of them were just kind of people weren't going to the hospital, even though they were very sick because they were scared. And, we're told we're told to stay home. So we, you know, I think when the pandemic really hit New York, I realized we would be hit just like with the programs that I oversee, but I don't think it was until we were in it that I realized just how bad it would be. I mean, of course, for the tenants, but for staff, particularly, like emotionally, it was very hard because I think that what happens is people are in crisis and they think that they're the only ones in crisis. And that's kind of like the human condition. We all do that, right? Like if I'm panicking, I'm not really thinking about anybody else around me. So people sort of forget that service providers are in this too. Service providers are experiencing this pandemic just like everyone else. They have kids, they have family, they have grandparents, they have moms, they have dads. They have people in their lives that they have to really worry about and themselves. We've lost our routine. There's so much mourning that has been going on. And I think that one of the things that has really helped with my team and my that is just kind of being there to just hear them out. Like, you know, I can't solve this for you and there's no perfect answer, but I'm here to listen and I'm here to, you know, to be what you need me to be. Not just to say, I think this is how you need to deal with the situation and as your supervisor, here's what we're doing. What do you need in this moment? And really encouraging them to take care of themselves because, you know, I think that when we all enter this work and into this field because we want to help others and we want to make sure that you know we sort of we leave this place better than we found it, right? But also there is a danger in putting other people ahead of yourselves constantly. So, and I feel like in this work, that's one, the message that they receive, whether it's on purpose or not. And we see it a lot in our culture, in our society. And so I would have conversations with staff, letting them know, like, if you need to take some days off, we can manage, we'll coordinate, we'll work on it, but don't burn yourself out because you need to have some of you, for your family, for your loved ones. And it's not easy, right? But we ended up to, some folks had to take a few days, you know, days of like just like mental health leave because it was a lot at once. And I think that it was hard to manage, but I think one of the things I told staff at the very beginning of this is like that someone told me I was having a lot of like very kind of like I don't know what I'm doing, and this is a lot to kind of work with our tenants. Someone said like, look, you know, in a crisis like this, airplane rules apply. Make sure that your mask is on, and then you can help put someone else's on, and that's kind of like the approach I've taken with staff and just making sure that they have what they need to be able to help themselves, then to help others, because we're not doing anyone any favors if we burn ourselves out entirely. So yeah, I think that just focusing on that and just being there for whatever they need in whatever capacity. Obviously, I'm not anyone's therapist, and I don't want to be, but just making sure that I'm supporting them through that, and that if someone's grieving, that we're kind of grieving together because we're all losing so much in this moment. So.
Great. Thank you so much for that. So quickly, we don't have a lot of time left, but there were some questions that came up. So, you know, feel free to jump in quickly. So I know one question came up was around, you know, I guess with the vaccine possibly coming out in 2021, will there be a citywide campaign that CBOs can join to help educate our seniors and work with them on any fears or information that, you know, that we're experiencing? I don't know, Dr. Batra, you have any thoughts on that?
I sincerely hope that our city will take this as seriously as we need to, get the vaccines out and work very hard on a public service campaign to make sure that people know the benefit of it. And I am going to take one and I'm going to tell my patients because I don't make them do anything I'm not going to do myself. There are a lot of questions. We don't know every single thing we need to know about every last detail, but if the vaccine is safe, effective, and I believe it is, then we need to promote it because this virus is a monster and we have to take it seriously. I know there's a lot of, you know, confusion and things, and there is a lot of question about all kind of vaccines, but I believe this vaccine is going to save lives. And we do need to know exactly who to get it when, but the city, I'm sure, will be leading the way.
Great.
Specifically, the Department of Health and Mental Hygiene is leading the way. They have a very active campaign now on the flu vaccine. There's a lot of prioritization and attention that they give to this, vaccines in general, and that would, even though it's not DIPTA, certainly that would be the assumption going forward. And DIPTA is in close conversation with them around what this will look like as more information evolves.
Great, thank you for that. So next question comes from Floyd. As a multi-modality housing provider, we also service some seniors living with HIV and AIDS and mental health conditions. We are finding that many have resorted to using alcohol and illegal street drugs during this time. How are you approaching the increase with the elderly engaging in these high-risk behaviors? Or have any of you, I guess, has that come down towards your organization?
I have noticed that.
Go ahead.
Sorry, I have noticed that. I have seen people going into behaviors that, are comfort behaviors for them, and being isolated is a trigger for a lot of things that led them to become homeless in the first place or to need supportive housing in the first place. So I have seen that. And again, it gets back to that iceberg. So maybe somebody has not picked up a drink in 5 or 10 years, but this is an extreme circumstance for them. So just being aware of what are their underlying, maybe something in the history. We do have supportive counseling on site. We have Dr. Foreman for telepsych, and she's been wonderful, very accessible. So we do have ways to help. And I think just acknowledging it, the stress, and being there for the person and saying, look, this is not a normal time of your life. Don't feel like a failure and hibernate even more is key. Just being there, reaching out, frequent contact, and not giving up on them.
Great. So I want to ask one question quickly before we kind of wrap up for Jocelyn. I think it's an important question. Could you discuss DIPTA's role in responding to the impending end of the eviction moratorium and any service available to prevent older adults from being evicted? I think just an important point to hone in on.
Yeah, tough question. So we're working closely with the Mayor's Office of Tenant Protection, which I strongly recommend that people look up if you don't have awareness of them. We had them come to a team meeting recently and present to all of our direct service staff, and they're pretty spectacular. So definitely recommend them. And they've given us some contacts that we could work with one-on-one to triage client-specific issues. We also, for clients that already been served with papers, we have our Assigned Counsel Project program, which works closely with HRA's anti-eviction legal services, and together we provide the social service and legal service components that are needed. We also work very closely with Adult Protective Services to support clients in this space. It's really about working with clients, acting as early as possible to make sure that clients are getting the resources they need, which could include things like SCREE or DRE, or opportunities if they need to relocate, things like our home sharing program, to really act early and connect with programs, citywide programs through HRA, like One Shot Deal or Home Base, to really preserve housing. And I will add, of course, we're hopeful that there'll be some rethinking around the end of this as we get closer to the end of the month.
Great. So we have about a minute or two. So I just want to, thank you for all the panelists. This is wonderful presentations and really informative information. And thank you for everyone who joined and, asked questions. And there's going to be follow-up. So we'll have a recording potentially in the next couple of weeks sent out. And then, we'll make sure that everyone has an opportunity, if it's okay with the panelists, share emails. So if there's any follow-up questions or specific things that, you didn't get to ask here. And again, thank you to the Health and Housing Consortium for bringing us all together. Thank you so much.